Hello, everyone, and welcome. I am Derek Snyder, and I am Senior Director for Science Partnerships and Outreach at the American Psychological Association. Thank you so much for joining us today, and please let us know where you're from by saying hello in the chat box. Today's program is an episode of Science Showcase, an APA webinar series on hot topics in psychological science research presented firsthand by the authors who did the work. We hope you'll continue to join us today and in future episodes as we learn from experts and emerging leaders, explore terrific new models and methods, and discover psychological science that inspires. Before we get started, I want to share a few quick announcements. First, thanks to all of you who submitted questions for today's program. We will try to get to as many of those questions as possible. You can also ask questions during the program by using the Q&A feature on your dashboard, and we'll add those to our list. Also, you may need to adjust the volume during presentations as some of those features are under the control of individual speakers. Finally, this program is being recorded. Everyone who registered will receive an email with a link to the recording in about 2 weeks. Today, we're here to talk about a topic that I believe is of interest to most of us in society today, and that topic is obesity. With 2/3 of the US population qualifying as overweight, that is having a body mass index above 25, and 1/3 of US adults identifying as obesity. This is clearly a problem that has broad societal and public health implications. In fact, 45% of people in a survey done globally recently say they are currently trying to lose weight. Now, we understand that obesity is a complex health condition that has roots in social behavior and activity and food choice and healthcare access and access to nutritious, healthy foods. So it is clearly a complicated phenomenon, but what has developed increasing attention in recent years is that obesity also has roots in some of the systemic disparities that exist in healthcare and in our society in general. For example, obesity tends to be more prevalent in communities of people of color. It is rising in low-income communities around the world as those communities go from a situation in which malnutrition is associated with being underweight to one that interacts with emerging technology to produce changes in activity and food access that often lead to low-income individuals becoming overweight. And obesity also interacts with long ignored or underappreciated issues in women's, race and ethnic, and LGBTQ plus health. And that's what we're here to discuss today. I'm pleased to have two knowledgeable speakers and experts on the role of disparities in obesity, Ashley Cooper and Sarah-Jean Salvi. And they'll be telling us more about their work and about the larger issues that disparities play in the obesity epidemic. And they'll also be addressing the question of whether lumping people into groups for the purposes of disparities research may be masking some of the more individualized issues related to the development of obesity. Our first speaker, Ashley Cooper, is a PhD student at the University of Pennsylvania School of Nursing. Prior to beginning her PhD, she worked as a nurse practitioner in primary care settings. Ashley's research examines the prevalence of obesity and cardiometabolic disorders in Black women in the United States, and how individual and institutional level discrimination influence cardiometabolic risk in this population, both in the context of social resource inequities and the physiological stress response. She seeks to engage in cross-sectoral, multidimensional work to translate her research into effective policy change. Ashley is a presidential PhD fellow and a Robert Wood Johnson Foundation Health Policy Research Scholar. We're so happy to have you with us today, Ashley, and we'd love to give you an opportunity to tell us more about your work.
Yeah. Thanks so much, Derek. Let me share my screen. Okay, so thank you again for having me. My research connects to today's topic because I study the ways in which the social environment influences weight status in Black US women. And so by that, I mean that I'm interested in looking at how psychosocial stress, typically framing discrimination as a chronic stressor encountered throughout the life course in a variety of settings and in many different ways, influences obesogenic related behaviors, like, for example, emotional eating, and may contribute to driving the prevalence of obesity among Black US women. And so I'd like to thank you, Derek, Allison, and the APA for inviting me to present some of the relevant findings from a recent review paper. So this is a narrative review on sex and gender differences in obesity prevalence, comorbidities, and treatment that was published in Current Obesity Reports in 2021. And I'd like to start off by acknowledging my faculty mentor, Dr. Ariana Chow, my co-authors, Sapna Gupta and Afaf Mustafa, and the Robert Wood Johnson Foundation Health Policy Research Scholars Program. So obesity, which is defined most commonly, as we know, as a BMI of 30 kilograms per meter square or higher, is a complex and multifactorial condition that's influenced by multiple mechanisms. It's a risk factor for several comorbid conditions, including diabetes, hypertension, depression, and some types of cancer. And according to the CDC, factors influencing weight status include, very broadly, eating and physical activity patterns, genetics, illness, for example, Cushing syndrome, iatrogenic factors, so medications like steroids, some antidepressants, and the social determinants of health. Obesity impacts 650 million adults globally, and at the time of publication, it was estimated that 11% of men and 15% of women have obesity worldwide. And in terms of the US, so these numbers for US prevalence have been updated to reflect the most recent prevalence estimates. So overall, the prevalence of obesity in adults in the United States is 41.8% for both men and women. And looking at severe obesity, which is a BMI of 40 or higher, we notice that the prevalence is statistically significantly higher for women than men. And if we further stratify by ethnicity, we notice even starker difference in the prevalence by race, ethnicity, and gender. So for example, obesity prevalence among Black women in the US is 57.9%, which you can see depicted on the figure on the right. And the patterns for severe obesity are similar. It's important to gain a better understanding of sex and gender as modifiers of obesity. We consider this an important step towards improving prevention and treatment. And so the purpose of our paper was to take a look at the recent literature related to the influence of sex and gender on obesity. And I'd like to spend our time together today reviewing some of the prevalence mechanisms and comorbidities that I think may be relevant and interesting to this audience. Obesity, as Derek mentioned, is a rich area of research. It's a complex and multifaceted topic. And in looking at some of the sociocultural and environmental mechanisms, we found that there are region-specific norms, customs, and beauty standards that influence eating and physical activity behaviors. We also found that there are gender-based food preferences that are shaped by the sociocultural environment. So that's things such as women's greater preference for and consumption of foods that are higher in sugar, which may be in part related to gender targeting of food advertisements and depictions of certain foods as masculine or feminine. There are also sex and gender differences in eating behaviors that are evident beginning in school-age children, which may be related to influences in appetite traits, as well as parental feeding attitudes. And related to psychological mechanisms, that there are also sex and gender differences in stress and social relationships. So for example, we see a stronger association in perceived stress and stress-related eating in women, and that's correlated with weight gain. Social relationships may be associated with psychological well-being and lead to weight gain. And these are also gendered. So for women, obesity measures were mainly related to marital status and social participation. And for men, social network size and living arrangements. In terms of physiological mechanisms, research that involves neuroimaging studies suggests that there are distinct sex and gender differences in structural, chemical, and functional obesity-associated alterations in the brain. Women demonstrated a greater neural response to food-related stimuli, which was positively correlated with BMI, and that was actually not observed in men. And also of note is the association of depression and obesity. And so in cross-sectional studies, obesity is more strongly associated with depression among women than in men. And in a systematic review, I think about 12 out of 20 articles reported that depression and obesity were comorbid in women, but not men. And so we concluded that obesity overall is generally more prevalent in women than men due to multiple factors, including sociocultural, environmental, and physiological differences. So in my research, as I frame the problem, I look at prevalence differences among women as a starting point. There are intersections among weight status, gender, race, ethnicity, and social and environmental factors. And studies targeting these social determinants of health are needed that include structural, social, and individual level factors and acknowledge these intersections. So, for example, in my work, I am currently developing a study that looks at associations of discrimination and emotional eating in Black US women. And so with that, I would like to thank you again for having me, and I look forward to our conversation and taking some questions.
Thank you, Ashley, for that introduction. We look forward to getting back to some of those fascinating questions.
Thanks, Sarah.
Our second speaker is Sarah Jean Salvi. And Sarah Jean is a professor of medicine at Cedars-Sinai Medical Center, and she's a research scientist in Cedars-Sinai's Cancer Institute. As the director of the Salvi Lab at Cedars-Sinai, her lab focuses on developing and implementing scalable and sustainable obesity and diabetes interventions across the life course. Much of this work focuses on environmental, intergenerational, and social transmission, and it seeks to understand how the world around us influences our behavior and overall health. Over the past 12 years, Salvi and her colleagues have spearheaded the cultural tailoring and clinical implementation of behavioral obesity and diabetes interventions in economically, ethnically, and racially diverse populations in both Southern California and Central Alabama. Dr. Salvi's extensive work has been published by a variety of journals across the disciplines of psychology, medicine, nutrition, exercise science, and clinical research. We're so happy Dr. Salvi could join us for this conversation, and please feel free to share with us some aspects of your work, Sarah Jean.
Thank you, Derek. I'm so happy to be here, very humbled and pleased to share this. So I'm going to start with sharing. So today what I wanted to share with you is less about contributors of disparity. I think we've done a pretty good job as a group of identifying which factors are leading to health disparity or cardiometabolic disease. And sometimes I feel it's kind of time to move forward and ultimately answering the question of what works for whom in which contexts and which circumstances, or whether the intervention we have worked for traditionally underrepresented segment of the population really require conducting rigorous trial in diverse, ethnically, racially, and otherwise diverse participants. And really the lack of diversity in weight management trial has really been challenging in terms of hindering our conclusion. So one more thing I'd like to say on the topic before presenting some of this work is that I often feel that individuals vary greatly within group, culturally or in the way they endorse the norm of their group. So I often favor tailoring based on individual rather than ethnicity, race, or gender identity alone. And I sometimes feel that tailoring to a group as a broad group end up overshadowing individuality and may end up being stereotypical in the process. So although I strive to address disparities in tailoring intervention, there's really always an effort to say, but what works for you and your family, or you and your social network. So I'm a psychologist by training, both clinical and experimental psychology. So I spend most of my time thinking of behavior change. my behavior changed, my 5-year-old behavior changed. And in the case of obesity, many people try to lose weight. You know, January 1st hit and you're like, okay, here are my good intention for the year. Yet a large proportion of individuals don't achieve clinically significant weight loss. And so why is that? And I don't believe the issue is knowledge, right? I still have to encounter 1% say, wow, I really didn't know that overeating donuts or triple cheeseburger was leading to weight gain. So sometimes I feel it's almost condescending the way we approach education, that people do know how to do this, but the real challenge is how you do it sustainably in everyday life, and how do you manage temptation, right? Adherence to treatment components is by far the strongest predictor of outcome, and sticking to treatment recommendation. Oops, sorry, I'm not in the good mode. Oh, here. So much better, right? Oh, no, sorry. So going back to what I was saying, adherence or sticking to the recommendation in everyday life is really the challenge, and it competes with all the other priorities that we may have. And so the priorities might differ depending on the color of your skin, your feeling of belonging, your social network, how you identify, but we're all dealing with this idea of bandwidths. And so that's really where the research, I think, aims to focus of how can we find strategy so that for people so that they are better able to manage temptation in everyday life. And when it comes to managing temptation, really people have two options, right? They can either resist temptation in exerting self-control, or they can avoid temptation in removing temptation altogether from under their nose. And so that's really what we're asking in the Avoid Resist trial is we're comparing avoid strategy and resist strategy. So everybody in the trial received Weight Watcher, and they are randomized to one of 4 groups. So Weight Watcher alone, Weight Watcher plus the avoid strategy, which is based on the premise that avoiding temptation altogether is necessary for weight loss. And so we teach them to modify their home environment, removing the temptation, being good to themselves. And after that, we provide them grocery delivery to ensure that they're maintaining a temptation-free home. The third group is Weight Watcher plus Resist. So in this case, where the premise is, well, it's never really possible to completely avoid temptation. So it may be useful to strengthen individuals' ability to resist temptation, to resist impulse when they're facing temptation. So those participants are asked to engage in daily impulse inhibitory control training, 30 minutes a day, in addition to Weight Watcher again. And the 4th group receive everything, which may be good because they receive everything, but it may also be bad because sometimes too much is actually too much, and it ends up decreasing adherence to those components. And so this trial is ongoing, and I'll be happy to answer any of those questions. I'll have to come back to present those findings. But so far, we've screened a lot of individuals. We have a very long wait list at this point. And since June 2022, we enroll 142 individuals. But the good news is that we have 50% of individuals who identify as non-Black, and actually 42% of individuals who identify as white are also identifying as Hispanic or Latinx. So although the very rich and diverse sample, we're recruiting across the country. So anyway, we're really excited about this. It's not a small feat, considering that most obesity trials include at least 80% white individual. Now, I just wanted to touch base on something that I may address later in some question, but it's the question of what works for whom, and the question of what works best for any individual. So dropout so far over the last now 10 months has not been outrageous. I mean, 23 out of 142, but who drop out is quite interesting. So only one person dropped out from the Weight Watcher alone group. 3 people dropped out from the combined, so Weight Watcher plus Avoid plus Resist. And everybody else really dropped out from Avoid or Resist. And we've noticed since the beginning that some people have an initial inclination of a preference. So I really think that this would work better for me, or I'm not a big fan of this. And this is one of the limitations of randomized controlled trial, is that we're assuming that people embrace whatever arm or intervention they're randomized to, but really those who are assigned for intervention that they don't like at all are more likely to drop out, or are more likely to be disengaged or not be adherent. And as I mentioned, adherence is the strongest predictor of outcome. So actually we're interested in looking and giving the choice to people and see if we cannot increase adherence and outcome to this. So I just want to take a minute to thank my colleagues on this trial, and I'm very excited to answer your question.
Thank you so much, Sarah Jean, for that insightful perspective. I'm going to start the questions with Ashley, and I wanted to touch on something that you touched on briefly that I think is often used as a proxy for some disparity conditions, and that's the role of stress in obesity. So can you talk to us a little bit about the role that stress plays in the development of obesity, and if all stressors are the same for all people?
I'm unmuted now. Yeah, so I'd be happy to. So the research is mixed, but more and more we're seeing that toxic stress, chronic stress, the cumulative stress burden across the life course is associated with higher body weight. And so this may be stressor specific, it may be context specific. So there are some studies that suggest that perceived discrimination, financial strain, relationship stressors, for example, were positively associated with BMI, whereas other stressors were not. And we also find that research suggests that psychosocial stress has a stronger association with obesity in women than in men. So research is mixed, but it really seems like it's chronic stress, the cumulative stress burden across the life course that really ends up contributing to higher weight status.
And you found that was more of a contributor in women than in men. I noticed that in your presentation, you cited so many characteristics that seem to affect women more dramatically.
Yes. So that includes social relationships, and then also preferences for more palatable foods that are higher in calories, higher in fat, and higher in sugar. Yes.
So these stressors not only have a downstream effect on the development of obesity, but they have them through distinct physiological mechanisms related to stress control.
Yeah, so for starters, stress might interfere with cognitive processes like executive function and self-regulation. It can affect behavior by inducing overeating and, again, consuming more palatable foods, by decreasing physical activity, and by shortening sleep too.
Sarah Jean, do you have anything to add to that?
No, I think Ashley did a pretty good question in terms of stress. I mean, I feel stress is one of those elusive area where there's probably as many findings showing that stress make you overeat versus, stress that make you undereat. And I don't believe we have identified those factors, right? So I often feel that finding adaptive coping strategy is a great avenue without, oversimplifying, there's some parallel with like smoking or alcohol. They would say, well, I'm stressed, I eat, or I'm stressed, I smoke. I'm happy, I smoke. And so I feel it's one of those factors where you finding, strategies to address those stressors, may be useful, but it cannot be used as kind of an argument to to justify all the instances where we eat or don't eat and those kinds of things. But I mean, obviously, stress hormones are interacting with metabolism of food and all of those things.
So I want to pose another question to you about the issue of comorbidities. I know
Yes.
that the research does involve other health-related conditions and how they feed into obesity as well. And so if you control for those other comorbidities, do you still find data that obese patients are at any higher risk than normal weight individuals?
I love this question, Derek, because it's been the oversimplification has been a little irritating to me, where we really tend to equate adiposity with, all-cause the disparity. And, I'll be happy to share with the group. I mean, very modestly, we did a study in 4,200 individuals in the early stage of COVID, but see if there was a relationship between adiposity and COVID severity and mortality. But the other group have done it better than us and in larger sample. And, what seems to be the case is that adiposity in absence of cardiometabolic disease is not necessarily related to morbidity or mortality, right? That it's not the weight per se, but really the disease that we tend to associate with obesity that may be more responsible for this. But maybe more important, and what I may read as kind of underlying text, and this is that obesity-related disease has been largely used to hold a stigma against obesity, right? It's like, so basically you need to lose weight because otherwise you're going to be, ill, and it's going to cost a lot of money to healthcare and all this. And I would argue that the best reason to lose weight is if you want to lose weight. And you may be encouraged to lose weight for medical reason, but if your heart's willingness and it's not in your plan, like if your heart is not in it and you're not committed to do it, treatment will only go so far. And so forcing someone to lose weight, in my opinion, is both a little ignorant of how those things work, but also morally questionable, because it's ultimately, even if it is 100% related to disease, if someone is not fully engaged in it, then it's going to have very little effectiveness, regardless of the nature of the treatment, right?
That's really interesting because, one of the bugaboos in society is about the idea of obesity being a moral issue. And what you're suggesting is that it's actually the other way around. It's the conformity that is a moral issue. So I want to talk about something else in terms of disparities that, again, is often used as a proxy for other things, but in itself might be important. And I'm going to direct this to Ashley first and ask about the issue of income inequality.
Sure. Yeah. So, we know that there are many facets or aspects to obesity, and one of which is that in many ways it's a health equity issue and is related to social disadvantage. And so in the article that I presented earlier, another thing that we found is that in higher income countries like the US, we generally expect that those with higher levels of socioeconomic status, so that includes higher household incomes, will have a lower body mass index. And that is because the pattern within this country is that people with higher incomes will have more access to resources. They likely live in better, safer neighborhoods. They likely have access to recreational programs and exercise facilities, and perhaps even a personal trainer. Leisure time, how many jobs do you work? People with higher incomes may be able to afford fresh food, vegetables, meat, and you can think of your last grocery bill and how expensive that was. And those with lower incomes may not be able to either as much or as easily engage in these lifestyle modifications and behaviors that that we talk about. And so when we think of all of the things that we do to maintain a healthy weight, most simply in terms of diet and physical activity, we can also think of how much more difficult that would be if we didn't have the same resources, which is not to say that it's impossible, but it's certainly more difficult. And I think also tying this to our stress conversation, there's some research that suggests that these inequities, so the effects of social disadvantage are also chronic stressors. And in many ways, this all kind of comes together as we discuss these social determinants of health. There's quite a bit of overlap in terms of housing and employment discrimination, income inequality, lower quality educational opportunities, debt, et cetera. So these all have the potential to add to the cumulative stress burden that we discussed earlier too.
Thank you for that. Sarah Jean, do you have anything to add to that? Because I know that some of your interventions involve situations that, if experienced in everyday life, might actually grow into an income inequality problem.
Yes, and I more and more, and actually this is a line of research that we're trying, but of seeing time or lack thereof, and even lack of autonomy over one's time is really health disparity, or is really a contributors of disparity. And I still and more calling exercise and like color green, or like fresh fruit and vegetable at the farmers market white privilege, right? And I feel that this is really hindering intervention, that we need to stop considering just structured exercise good for health, right? Occupational activity, all the movement that we're doing throughout the day contribute to health. And I feel that even the guidelines and recommendation being based on quality and quantity really reinforce this narrative. And it's easier, and it doesn't have to be that complicated, or to really have to make time to go exercise at a structured activity. So of trying to widen the recommendations so that they're more accessible, and not even accessible in terms of being able to get them, but being feasible for people to do. And in the same way as like walking around the mall, or walking around your house, or dancing on Baby Shark, or whatever is groovy for you, is all considered movement and activity, and should be integrated. And that frozen or canned vegetable are totally great alternative. So yes, but time as a constraint is definitely something that I'm thinking more and more, and how even someone's allocation of time throughout the day is not a contributor to obesity. So that's actually a research that we're pursuing. So yeah.
So that's an interesting segue into my next question, which is about the traditional advice to, just eat less and move more, and you'll lose weight and be fine. Is that good advice? Is that good advice for everyone?
Yeah. It's such a great question, right? And so I don't know, for those who are like avid Twitter, there's debate about how sound the eat less calorie then you expand. I would say continue to be true, but regardless of how accurate this advice is, it's also probably the least useful standalone advice I can think of. My husband went to the physician recently, and it was like, okay, you need to lose weight, you know how to do it, calorie in, calorie out. And the problem is that like people know, again, I still have to encounter someone who's like, oh, I really didn't know this is, what I needed to do. But really, what we're saying is calorie consume, calorie burn. But to successfully do this on a daily basis, what we're really saying is you're going to have skills in time management, financial literacy, food shopping, nutrition label literacy, food preparation, finding time to exercise in the typical, guidelines way, portion control, creative way to have your child, eat those food. And so, we're not teaching people how to do those things, and we're implying that education alone is a behavior change strategy. And I feel this is where we're failing. Now, with regards to intervention, working with everyone here, what I would say, surgery, behavior change, meal timing, pharmacotherapy are all viable options. But you actually need to do those things. I'm sorry to break it to you, but surgery can be super effective. If you don't show up, surgery is not going to work, right? And so, and this is even harder for behavior change intervention, where, what we're intending to deliver and when we're intending people to receive, there's often a really big gap, right? We can't judge an intervention if people don't do it. If you don't take your statin's not going to work for you. And I don't need a crystal ball to know that. So again, adherence treatment is the strongest predictor, and ultimately the best strategy for any given individual is something they're able and willing to do consistently and for a long period of time, right? So in other words, how you will make this work if you want to, because you don't have to if you don't want to, but if you want to, is selecting a plan or something that jive with who you are based on, your willingness to do it, et cetera. It comes back to this, my findings about dropout and trial. If a strategy doesn't work for you or you don't believe in it, it's not going to work. So I'm not saying it's going to be easy. It won't. And that's another of my pet peeve, where I feel that we're telling people, oh, it's going to be really easy. We're going to remove all the barrier. You really don't have to do anything to lose weight. And that, I feel we're lying to people, because it is hard. But working towards something you really want and are willing to do is very different than adopting strategy you don't believe in or profoundly dislike, right? So
You make it all sound very stressful and like a lot of things that people have to learn in order to be successful at this, which I guess kind of speaks to some of the inequality issues that you mentioned with regard to having the time to focus on these things. Ashley, did you have anything you wanted to add?
No, I think that was all beautifully said and really interesting.
Well, all of this is leading into my next question for you, which has to do with the types of advice that people get in healthcare settings about overweight and obesity, and how those common practices might reflect bias and discrimination towards particular groups of individuals or toward overweight and obese people in general, and how that affects people's willingness to take in that information and to seek out healthcare solutions.
Yeah, that's a great question. So I know that there are studies that demonstrate that persons with obesity, they encounter stigma, interpersonal weight stigma, in many different settings, but it's most often encountered by physicians and family members. So in terms of healthcare settings, though, it's not just physicians, it's across all roles, across all levels of training. This includes medical students, nursing students, and some of the findings of recent studies are that no less than about 50% of healthcare professionals indicated some implicit or explicit weight bias. And also that experiences of weight bias and internalization of bias are cited as primary barriers to engaging in and seeking healthcare. For individuals with overweight and obesity, constantly encountering bias is also a chronic stressor and may be a stronger predictor of worse behavioral, psychological, and weight loss outcomes, as well as other health outcomes. So how can this be changed? First, I think it's important to recognize and acknowledge our own biases. So just so that we're aware of and careful in our communication with patients with overweight and obesity. From a clinician standpoint, I think we want to make sure that our conversations surrounding body weight are relevant. So if someone is coming in for, let's say, like a splinter, this might not be the time to tell them to lose weight. And that also could be interpreted negatively by the patient and prevent them from seeking care. Not only in terms of weight control care, but also in terms of primary care, acute care in general. And we also want to make sure that we are providing comprehensive care to all of our patients across the board. So for example, healthy diet and physical activity, I know we keep coming back to that, but these are topics that should not only be addressed with those that we perceive as overweight or obese. These are conversations that we need to be having with everyone. And we also want to make sure that we have bias training for clinicians and staff and weight inclusive environments. So chairs that folks of various body sizes can easily fit into, privacy when weighing, a scale that accommodates higher weights, and so on.
That's a really great and comprehensive answer to that question. Sarah, do you have anything to add?
I don't like, I mean, this idea of stress and chronic stress, I think touched to the question of bandwidth that I was mentioning, right? And so that's the more and I don't know about you, Derek, but it's, you know, it can be health, it could be finances. And I really feel finances is a moving target, right? It's like it's always there, like being head of household, having support, my family and not knowing if I'm going to have a job next month, all of those things are real for me, and for other people. And I'm not saying that, my stress are bigger or than other people. We all share those things, right? And under these circumstances, when we need to address and pay attention to health, finance, are your friend okay? Is your family okay? Bombarded by news and things like that. That's if a diet or whatever you want to call it, an intervention is complex, it's not going to be sustainable in the long term. And so trying to find everyday strategies to incorporate those advice or guidelines, but in a way that doesn't require to expand your bandwidth, because again, finding time to do this and fit this is very like white upper class privilege, where we don't, it's not everyone who have access to those things. And so and it touched also this question of time, where women also tend, even to this day, to have more to combine paid and unpaid work, which further decrease the amount of available time to engage in those recommendations, right? So it's stress less as an emotional feeling, but more as in terms of constraint on what you can and cannot do, and where you end up eating at midnight, because that's the only time you have time to actually eat, right? There was also a question in the chat, and I don't know if I'm overstepping my boundaries in answering this, but in terms of how economically diverse people in our studies are, and is this idea of grocery delivery feasible or reasonable for lower SES or folks with lower income. And so our sample is pretty diverse also economically. And we chose Instacart because they use multiple stores that are available in all income neighborhoods or across the strata, but also that cater to different cultures. But we keep repeating, look, if grocery delivery is not something you want, I think during COVID, it became increasingly available with no extra cost. Of course, in the study, we defray the cost of grocery delivery because it's a study, but it's more a strategy to how do you avoid bringing things in your home that you will regret. We've all been exhausted at the end of the day, and you drive, and there's a McDonald's or drive-through there, and it's, I'm starved, I don't have energy, I don't have regulatory resources, or you go to the grocery store and they're happening to bake fresh, whatever pastry, and the temptation. That's what we're trying to do with the grocery delivery. We're not saying grocery delivery necessarily has magical power, but it's how can we shield people so that they are master of their domain. And so if that, of be good to yourself and don't bring temptation in your home if that's not within your plan. And we're not saying it's not, don't go ever to the, fast food or anything, but to have control and feeling empowered about when and how, which often is impossible. If you have it at home, it's much easier, it's much harder to resist it. So yes, our sample is economically diverse. And I think there's alternative strategy, to provide the same result. I work with very low income mothers and their infants, and they're food bank recipient and SNAP, and these strategies are able to make it work based on SNAP, and even receive the delivery because they live in very, very remote and isolated area, and they don't have transportation. So I'm not saying it's the recipe or the solution to everything, but it's more about how do we help people being good to themselves in their home rather than providing luxury, grocery delivery, if that makes any sense. So.
No, that does. And it's interesting how you frame grocery delivery as an sort of an aid for self-regulation, and as a way to avoid that one-on-one interaction with the food in the store that might break you down and lead you to choose to bring that food home and thus to consume it. I hadn't considered how the pandemic was really a global experiment in having to receive things at home, but also in breaking down our mental health. And what did you see happening during the pandemic in terms of the interplay between wanting that comfort food, but also needing to receive it remotely? And, did the pandemic help us in terms of obesity risk, or did it hurt us?
Well, no, I mean, like I sometimes say that, COVID was a much more effective intervention than all our trial combined, right? So all our intervention fell in the water during COVID because the priority, that what was at the forefront was like, I really don't care about carrot or cucumber or about being fit. I'm just trying to survive right now. And anxiety was so high. And, I don't think we're back to even COVID's food insecurity, right? So it really marked us. But it's also being at home surrounded, when you get out of the house for a reason or another, you're not in constant presence of food. So combining the need to have comforts, right, from like a good friend, and feeling socially isolated. And so, but also having access, right? Like I'm comparing it to summer weight gain in children. They don't have structured time. They have more access to foods. Probably both their parents are working. And so, there's less supervision in terms of what do you eat or what do you do? And it results in, the perfect storm of increased access to easy to prepare food, increased sedentary behavior, and less structure, right? And that's basically what happened during COVID, where with the underlying anxiety of, oh, I'm gonna die and I need to protect my loved one, right? So.
Ashley, do you have any thoughts on the role of COVID and the pandemic in all of this?
Wow, I was just sort of thinking to myself that I was a nurse practitioner in Brooklyn during the first wave of COVID, and I think that was the first time that I'd experienced anything resembling food insecurity myself. Just having to work all day and then coming back and having the supermarkets be completely bare, and how stressful that would have been had I not had the social resources to have friends bring food from different grocery stores in different parts of the city and things like that. And so I think that the experience of COVID overall, especially within that first wave, was really challenging in many ways for many folks. And, especially I'm just thinking of that instance of food insecurity for myself, and the ways in which that sort of impacts. Yeah.
Well, I want to take this moment to thank you for your service. And
Thank you.
also to point out the types of stresses that maybe the rest of us who aren't frontline workers didn't really recognize during that time. So I would do this if I could bring up recent interventions for obesity treatment. I think that for decades, people have joked about there being a magic pill for obesity. And when gastric surgery came along, people expressed concerns about it, but largely treated that as though it was a big advance in the treatment of obesity. And now we've had this craze regarding movie stars using the pill Ozempic. And just today there are reports of clinical trials for 2 more anti-obesity drugs that may be entering the market soon. What are your thoughts on all of that? We've gone from a situation in which we talked about obesity primarily as a behavioral issue, and we're entering a world where it's largely, or at least more often, being treated as a purely medical issue that can be reduced with a pill. Thoughts?
I do, because it's been a big discussion, especially because with the new American Pediatric Association guidelines, right, where they're basically recommending the whole kitchen sink, right? So, treating aggressively, even in childhoods, like pharmacotherapy, surgery, and all of this. And I know there's big interest on this. My original hesitation or issue was on the shortage, where really it was, a privilege, medication, and like everybody else, like everything else, only people who could afford it had it. And then also of taking away from, people with diabetes who are actually needed the medication. Now that the supply, pharmaceutical company know what's good for them. So with greater supply and the ability to, provide, I mean, there's nothing wrong with pharmacotherapy. We haven't seen any side effects so far. I see it as one of the tools that someone has in the arsenal, right? Some people may be really reluctant, have strong attitude against medication, feeling that it deprived them from their will, right? So like, I want to be the one who succeed. I don't want this to come from a pharmaceutical agent, right? Those change pathways, people have strong preference, and that's okay. It's one of the tools that we have available. It may be useful to kickstart weight loss. Weight loss, especially if you have a large amount of weight to lose, is long, and it requires an insane amount of grit, of day in, day out, continuing and not being detracted from, this goal. And so I'm all in favor, and hopefully with the increase in accessibility, it start being recommended to more people who were not receiving originally. But I think that the question of disparity with regards to medication applies to everything, like specialized obesity clinics that are evidence-based. There are not many of those, and people in rural area don't have access to those treatment, right? And Weight Watcher did really great in expanding to a remote platform and maintaining effectiveness so that everyone, even if they were not living in a large center, could actually benefit from this. So again, Ozempic is not going to work if you don't take it. So the question of adherence is still working here, but I think it's good to be flexible and just see it as one other option, as long as it's available to everyone.
Ashley, with your past as a nurse practitioner, I'm sure you have a thought on this as well.
Yeah, I wanted to echo something that Sarah says, that it's a tool in your arsenal. I also think that the issue of accessibility, cost, is really important, especially since we see, again, in terms of patterns of obesity in the US, that those with lower socioeconomic status have higher BMIs, right? And so one thing that I hope is that in conversation with your healthcare provider, if your provider, you and your provider, if a person in their provider decides that this is the avenue to go, that it is accessible, that it is covered, that all people who need this medication have access to it. And I think that that's something that we need to make sure of.
Thanks. So I want to end on a hopefully positive note. Despite the inequalities that we've talked about today and their outsized influence on one's susceptibility to gain weight and to also have trouble taking it off, we've heard some evidence that maybe it's not healthy to be telling everyone to lose weight. And we've also heard some evidence that there's a toolbox that we can be using in medical and psychological efforts to combat the obesity crisis. So what message would you leave for someone from a low-income community who doesn't have a lot of resources, who may be a person of color, who experiences trauma in their everyday lives and has gained a lot of weight? What message would you leave for that person?
Sister, brother, I'm sorry, that's a lot. And I'm not saying this as a joke, but I'm saying, it's one of the thing. And during COVID, that became really salient, that, we have priority that are becoming, that are coming in and out of focus. Someone who has repeated trauma and whose safety, is currently endangered. I mean, I'm not sure weight loss should be, at the forefront, but I think we need to change the narrative of being good to oneself, right? And that it's not a question of weight loss, it's a question of self-care in the same way as, brushing your teeth or, ensuring that your children are warm when it's cold outside. And starting small is that, I'm a strong believer in those little things that you do every day that are simple, but can also provide a feeling of accomplishment okay, today was chaos. Today was just really awful, but I, ate a banana with my son this morning. And, it's those little things that in the long run of changing those short habits in daily life, that may be more of a solution. Replacing soda with water at dinner time, it may be just this, but if you do it consistently and every day, it does accumulate over time. And not, having self-worth related to adiposity, that it's not for others, or, it's really about refocusing on a balance and those things that we can control, because there are so many we cannot. So.
Thank you, Sarah-Jean. Ashley, any parting thoughts?
Yeah, I wanted to echo some of what Sarah said, that perhaps now is not the time for weight loss. Perhaps now is the time for prioritizing self-care, engaging with providers and resources in order to really take care of yourself. And weight loss can happen later, but it doesn't. I would not frame that as a priority for a person who is experiencing that much. So.
I love that message, and I hope our audience does too. Thanks so much to Ashley and Sarah Jean for joining us today. We really hope you, our audience, enjoyed today's discussion. You'll be receiving a 1-minute survey to complete after today's broadcast. We really value your feedback, both on this content and on topics you'd like us to cover in future episodes. So please complete the survey and feel free to email us at science@apa.org with any recommendations you have for us. Finally, we invite you to subscribe to Science Spotlight, which is your source from us for the most relevant news and information for psychological scientists by psychological scientists. Special thanks again to our speakers. We deeply appreciate your time and support. A huge shout out to our production team. She always makes me take this out and I always put it back in. Specifically, Allison Spanos, our producer, for coordinating everything behind the scenes. Most of all, thanks to you, our viewers. We're here for you and we hope to see you at our upcoming events. I'm Derek Snyder with Science Showcase, and I wish you a good day.